Hi, welcome to this first lecture of Anatomy of Lower Extremity in our series for Orthopedic Board Review. A good source that you can use is this book written by myself. The first thing that we're going to discuss in this lecture is the approaches and the important points that commonly come in the exam. So we'll start with the approaches for the bone grafting from the iliac crest, which can be anterior or posterior. If you are harvesting anterior iliac crest, the structure at greatest risk is the lateral cutaneous nerve of the thigh, which passes about 2 to 3 centimeters medial to the anterior superior iliac spine. If you are harvesting graft from the posterior iliac crest, which is usually in spine cases, lateral extension, the structures at risk are the cluneal nerves, which is usually about 8 centimeters lateral to the posterior superior spine. With distal extension, the structures at risk are the superior gluteal neurovascular bundle. Another approach that commonly comes in the exam is the ilioinguinal surgical approach. This approach is commonly used for acetabular fracture for associate both column. The point that comes in this approach is the iliopectineal fascia. The iliopectineal fascia separate laterally the iliopsoas muscle and the femoral nerve from the vascular structure medial to it. The vascular structures are the iliac vessels, which will become after that the femoral vessels. The femoral nerve and artery are medial to the iliopectineal fascia. The iliopsoas muscle with the femoral nerve lies lateral. So as you can see here in this illustration, this fascia needs to be released so that you can reach to the proper pelvis. So this fascia needs to be released, which separates between the vessels medially and the muscles with the nerve laterally. Another approach is the stoppa approach. Also, this approach is used for acetabular fractures. It's used becoming more and more common now. And this approach, as you can see, gives you the best view for the quadrilateral plate. So if you're asked what is the best approach for to access the quadrilateral plate, it's the intrapelvic, anterior intrapelvic approach, because it's directly over the quadrilateral plate. The structure that is at risk in this is the corona mortis. The corona mortis is, if you're asked what is the corona mortis, it is anastomosis between the external iliac vessels and the obturator vessel, and sometimes in some cases the whole obturator is actually coming from that anastomosis. So the corona mortis is anastomosis between the obturator, which comes from the internal iliac, and the external iliac vessel, and this corona mortis is usually about 6 centimeters from the symphysis pubis. So if this is the symphysis pubis, about 6 centimeters laterally on both sides, you will find the corona mortis, which is basically anastomosis between the external iliac and the obturator, which comes from the internal iliac. After we talk about acetabular approaches, we're going to talk about hip approaches. We'll start with the Smith-Peterson approach or the anterior approach. So here are a diagram for the approaches of the hip. The anterior approach is between the sartorius and tensor fascia lata. If you go between the tensor fascia lata and the gluteus medius, this is the anterolateral approach or Watson-Jones. You can go through the gluteus medius, which is the hard hinge or the lateral approach, and of course you can go through the gluteus maximus, which is the posterior approach to the hip. We'll start with the anterior approach or the Smith-Peterson approach. The Smith-Peterson approach is actually the only true interneural approach to the hip, because the sartorius is supplied by the femoral nerve, the tensor fascia lata is supplied by superior gluteal nerve, deep dissection is the rectus on one side, which is supplied by the femoral, and the gluteus medius, which is supplied by the superior gluteal nerve. So the anterior approach or the Smith-Peterson approach is the only true interneural plane. As we're going to see with the three other approaches, they are not true interneural planes. The anterior or the Smith P is true interneural between the sartorius, which is supplied by the femoral, and the tensor fascia lata supplied by the superior gluteal nerve. People are now more interested in the anterior approach of the hip because the anterior anterior approach for total hip replacement is becoming more and more popular. So you need to know this approach because it becoming a more commonly asked question. There is two structures at risk. The lateral femoral cutaneous nerve, as we said, the lateral cutaneous femoral nerve lies about 2 centimeters medial to the anterior superior spine, and actually is in the sartorius sheath. So the nerve goes into the sheath of the sartorius muscle. So that's why most of the surgeon now, instead of going in the interval, will open the fascia of the tensor fascia lata and go retract the muscle, and then go through this fascia to try to stay away from the lateral cutaneous nerve. So the lateral femoral cutaneous nerve is at risk in this approach, and remember, it lies in the lateral part of the sartorius sheath. Another structure at risk is the ascending branch of the lateral femoral circumflex artery. So this is the femoral artery. It gives the lateral and medial circumflex artery. The lateral circumflex femoral artery will give a branch called the ascending branch. That ascending branch goes between the sartorius and tensor fascia lata over the rectus muscle, and it has to be ligated. So lateral femoral cutaneous nerve and the ascending branch of the lateral femoral circumflex artery, these are two structures at risk for this approach, which is becoming now more popular because the anterior approach to the total hip is becoming a more popular approach. The second approach will be the anterolateral, or the Watson-Jones. So we said that the anterior approach is between the sartorius and tensor fascia lata. The anterolateral will go one step posterior, so it will be between tensor fascia lata and gluteus medius. So it's going to be between the tensor fascia lata and the gluteus medius in this part. So this will be the anterolateral approach, and it will take you to the anterior part of the neck. So anterior approach between the sartorius and tensor fascia lata, anterolateral between tensor fascia lata and gluteus medius. And if you notice, both the tensor fascia lata and gluteus medius are supplied by the superior gluteal nerve. So this is not an interneural approach because both muscles are supplied by the same nerve. If you go one more step back, it will be direct lateral or hard hinge approach. In this approach, you go through the gluteus medius muscle. So the first one between tensor fascia lata and sartorius, and then between sartorius and gluteus medius. That one will go through the gluteus medius muscle, and it will split the gluteus medius. But you should not go more than 5 centimeters from the insertion, because you may affect the superior gluteal nerve, and you may affect the muscle, the nerve supply for the muscle. The anterior half, or the anterior 2/3 of the gluteus medius, are reflected together as a flap with the anterior part of the vastus lateralis muscle, and they are pushed or peeled anteriorly, and then the hip can be approached from that interval. So again, this is still not a true interneural approach, because it's actually go through the same muscle, which is the gluteus medius. Care should be taken not to extend too much proximally to avoid injury to the nerve. The anterior half, or 2/3, together with the anterior half of the vastus lateralis, are reflected, and then in the deep part, the gluteus minimus and the iliofemoral ligament will be detached to reach to the anterior hip and dislocate the hip anteriorly. So in this approach, the hip is dislocated anteriorly. So if you're doing a total hip or hemiarthroplasty, this patient will have anterior hip precaution. So the lateral approach, after you reflect the anterior half of the gluteus medius, the gluteus minimus and the iliofemoral ligament will be released, and then the hip will be dislocated anteriorly. The last approach is the posterior approach to the hip. It's very commonly used for hemiarthroplasty and total hip. It's through the gluteus maximus muscle, which is supplied by the inferior gluteal nerve. So remember, the gluteus maximus is supplied by the inferior gluteal nerve, while the gluteus medius is supplied by the superior gluteal nerve. So posterior approach is through the gluteus maximus, supplied by the inferior gluteal nerve, and then after that you relieve the piriformis, obturator internus, and the two gemelli. This approach has a slightly higher dislocation rate, so it's recommended that you repair the capsule after the approach. Another approach rarely uses the medial approach, sometimes used to reduce the hip dysplasia in very young infant. The dissection is between the gracilis on one side and the adductor longus muscle, and that's in the superficial layer, and deep dissection will be between the adductor brevis and adductor magnus. Superficially the adductor longus and the gracilis, and then after you retract them, you will go or release the adductor brevis and adductor longus muscle. This approach is rarely used, not as common as the other approaches. Sometimes it's used to reduce the hip dysplasia in young infants. Arthroscopy approaches sometimes comes in the exam. Remember that the posterolateral approach is close to the sciatic nerve. What you do is you internally rotate so that you bring the femur away from the sciatic nerve. So the posterolateral approaches, you'd like to, this is close to the sciatic nerve. In order for you to get the portal a little bit further from the sciatic nerve, you internally rotate the hip so you can bring the femur and the troch more lateral and away from the sciatic nerve. Anterior portal, again close to the lateral femoral cutaneous nerve. So the lateral femoral cutaneous nerve keeps coming with many approaches. It came to us with the anterior iliac harvesting, and it came with the anterior approach, and also it's with the anterior portal for the hip arthroscopy. Also the same thing, it's close to the ascending branch of the lateral femoral circumflex artery, which we said is also a risk for the anterior hip approach. So the two structures risk for anterior hip approach are also close to the anterior portal. The anterolateral portal, this is close to the superior gluteal vessel. So the anterolateral is close to the superior gluteal vessel. So the posterolateral close to the sciatic nerve. You can be a little bit safer if you internally rotate the hip. Anterior portal has the same structure that are at risk for the anterior approach of the hip. Anterolateral, this is close to the superior gluteal vessels. Another important approach that you need to know is how to do the open surgical dislocation with trochanteric osteotomy. So if you'd like to do to address intra-articular pathology of the hip, like cramp impingement or fracture, you will need to dislocate the hip in a safe way that does not affect the blood supply. So quickly to go through the blood supply of the proximal femur, it comes mainly from the medial femoral circumflex artery. So the medial femoral circumflex artery gives about 75% of the blood supply of the proximal femur. It comes from the femoral artery, from the deep femoral artery, and then it passes posteriorly between the pectineus and iliopsoas, and then go across the obturator externus, and then passes anterior or deep to the external rotator. In order for you to keep the blood supply, you may need to make sure that the medial femoral circumflex artery is not affected. This muscle, the piriformis, is an indication that the muscle is the medial femoral circumflex is not injured, so you need to keep this muscle intact and attach it to the stable trochanter in order for you to make sure that the medial femoral circumflex artery is maintained and not injured. So you will do the trochanteric osteotomy. It's called digastric osteotomy. It has the gluteus medius on one side, vastus lateralis on the other side. How to know that you will not cut the piriformis? The best way is to leave about 1 millimeter to 2 millimeter of the gluteus medius attached here. That's an indication that you're going to leave the piriformis intact. That sometimes comes in the exam, is the osteotomy needs to be anterior to the posterior edge of the gluteus medius by 1 to 2 millimeters. So you need to, meaning that you need to leave about 1 or 2 millimeters of the gluteus medius attached to the stable trochanter, while most of course of your gluteus medius and the vastus lateralis would be attached to the mobile piece of the trochanter, which is usually about 1.5 centimeter in thickness. And then you need to do what's called the Z capsulotomy. The Z capsulotomy, again, we said that the blood supply, the medial femoral circumflex will go anterior to the external rotator and then pierce the capsule here and give the blood. So you need to make sure that this stays intact. So you'll do your Z cut in the capsule. The longitudinal one is across the antero-superior border of the neck. As you can see here, this is anterior, this is superior. So this is along the antero-superior border of the neck. And then the proximal can go posteriorly across very close to the acetabulum, so you're away from the blood supply here. So your cut here should be at the acetabular level, not at the trochanteric level, so you can keep the blood supply intact here. Anteriorly, of course, you can go into that direction anteriorly. Just don't go pass across the lesser trochanter, so you don't come to injure the vessel into where it comes from the posterior part. So this is the longitudinal part across the anterosuperior neck, proximally extend posteriorly across the acetabulum, so you are far away from the vessel, which are here, and then anteriorly you can go in the direction of the lesser trochanter, but don't cross to the level of the lesser trochanter. This is of course posteriorly, so that you don't come to meet the vessel where it comes here in the posterior part. Now we have finished the important points in the surgical approach of the lower extremity. We're going to speak about some of the points that are commonly asked in the exam in the pelvis and acetabular anatomy. So this is a picture for the pelvis from the back. This is the sacrum, this is the iliac bone, and this is the proximal femur. We have the greater and the lesser sciatic notch. What separates between them is the sacrospinous, between the sacrum and the spinous process, into a lesser sciatic notch and greater sciatic notch. In the lesser sciatic notch, we have the obturator internus muscle with the two gemelli. In the greater sciatic notch, we have the piriformis muscle that we talked about in the previous slide. And the piriformis muscle separate between structures going above the piriformis and below the piriformis. Above the piriformis, that's very easy, the superior gluteal nerve and artery. Below the piriformis, we have sciatic nerve and posterior femoral cutaneous nerve. We have also the inferior gluteal artery. So the superior gluteal artery and nerve go above, inferior gluteal artery go below. And then we have the internal pudendal artery and the pudendal nerve, both also go inferior to the piriformis. There's two other nerves that are not depicted here in the picture, which is the nerve to obturator internus and nerve to quadratus femoris, also go below the piriformis. So greater and lesser sciatic notch separated by the sacrospinous. The lesser has the obturator internus, the two gemelli. The greater has the piriformis muscle. Above is the superior gluteal nerve and artery. Below, sciatic nerve, posterior femoral cutaneous nerve, inferior gluteal, so inferior below, superior above, pudendal nerve and internal pudendal artery, and two small nerves, nerves to obturator internus and nerve to quadratus femoris. Remember that the superior gluteal vessels exit the pelvis by passing around the superior gluteal notch. So sometimes you get a CT angiography and you will find a vessel turning around the superior gluteal notch, and you will ask it, B, what is this vessel? It is the superior gluteal artery. So the superior gluteal vessels exit the pelvis, passing around the superior gluteal notch. So they take this sharp turn here, and they may be injured in pelvic fracture. So they are important clinically. If you get a CT angio and you see a vessels turning around, making a turn here in the superior gluteal notch, that's most probably the superior gluteal artery. As we said, the superior gluteal artery and nerve both passes superior to piriformis muscle. We spoke about corona mortis before when we were discussing the anterior intrapelvic approach. The corona mortis is anastomosis between the external iliac system and internal iliac system. The internal iliac system anastomosis is through the obturator vessel. The external iliac can be directly from the external iliac or from the inferior epigastric, which is a branch of the external iliac. As we said before, this anastomosis is usually about 6 centimeters from the symphysis pubis. In approaches that uses the inner part of the pelvis, like fixation of the symphysis pubis by phenostyle incision, or the stoppa, which is the anterior intrapelvic approach, care should be taken to ligate the corona mortis before extending more posteriorly to avoid injury of these vessels. Another important structure in the pelvis is the L5 root, which you can see here. The L5 root passes anterior to the sacral ala. So in cases you are putting an iliosacral screw or transsacral screw, if the screw is anterior, it may injure L5. So you may get a question into your exam. They present a patient with a transsacral or iliosacral screw that is anterior. They may ask you what is the possible injury. It will be L5. Sometimes they go a little bit deeper and ask you what muscles can be affected. Remember, it's not only the extensor hallucis longus, also the abductor, the gluteus medius, is supplied by L5 root. Also, this area here is important. You need to know that this nerve, the L5 root, is usually about 2 centimeters from the sacroiliac joint. So if you want to put a fixation, anterior fixation here like a plate, it should not go more than 1.5 centimeters because it may result in injury. Also, when you're putting homens here over the sacral area, you should not put it more than 1.5 centimeter medial from the sacroiliac joint because you may injure the L5 root. We discussed before the blood supply to the proximal femur in the surgical dislocation approach for the surgical dislocation. In this slide, we're going to speak again about the blood supply for the proximal femur. As we said, the deep branch of the medial femoral circumflex artery, this is the main blood supply for the proximal femur. In the first 4 years of life, the proximal femur will get significant blood supply from both the medial femoral circumflex and the lateral femoral circumflex, with some minor blood supply coming from the artery of the ligamentum teres. However, after that, as we said, most of the blood supply will come from the medial femoral circumflex artery. The medial femoral circumflex will come from the deep femoral artery, and then it will go in between pectineus and iliopsoas, passes posteriorly, and then it will travel along the quadratus femoris. So it will be here over deep to the quadratus femoris, and then it will passes proximally anterior or deep to the obturator internus and the two gemelli, and after that it will pierce the capsule and give the blood supply. If you're doing release of the iliopsoas, the artery may be at risk. As we said, it passes between the iliopsoas and the pectineus. Of course, if you're doing nailing through the piriformis, especially in a young patient, the vessels, the terminal vessels, may be at risk, and there is a small risk for developing avascular necrosis. Also, it's important to know that the inferior gluteal artery will anastomose with the deep branch of the medial femoral circumflex, and this anastomosis is important for the blood supply. There is a minority of cases that the dominant blood supply to the femoral head comes actually from the inferior gluteal artery. Remember that both medial and femoral circumflex artery comes from the deep femoral artery or the profunda femoris artery. So blood supply to the femoral proximal femur, mainly deep branch of the medial femoral circumflex. It comes from the profunda femoris. It goes between pectineus, iliopsoas, and then passes along the deep to the quadratus femoris and close to the obturator externus muscle, and then it passes proximally. When it passes proximally, it crosses anterior to the obturator internus and the two gemelli, and then it pierces the capsule. Remember, when it goes proximally here, it's usually about 1 centimeter from the edge of the trochanter. So if you're doing acetabular Coker-Langenbeck approach to preserve the blood supply, we do the cut of the muscles here about 1.5 centimeter in order to preserve the blood supply to the proximal femur. Blood supply of the proximal femur is a very important topic. It comes in the exams frequently. You need to know all the information related to this blood supply. The medial femoral circumflex artery is very important to know the anatomy, its relation to the obturator externus, its relation to quadratus femoris, and its relation to the three external rotator, the obturator internus with the two gemelli, and then how it pierces the capsule and start giving the terminal branches. Remember, inferior gluteal artery anastomose with the medial femoral circumflex and gives significant blood supply in some cases. In the pelvis and acetabulum, there's two teardrops that we mentioned. First teardrop is the teardrop here of the acetabulum. It's mentioned in the acetabulum fractures for the landmark that we use in the x-rays. Also, when we're doing the total hip, that teardrop is important landmark. This teardrop is basically the area of the bone between the cotyloid fossa, which is this area here, and the quadrilateral plate. So this teardrop is that area of the bone here between the cotyloid fossa and the quadrilateral plate. Another teardrop is the corridor of the bone between the anterior inferior iliac spine and the posterior superior iliac spine. This corridor of the bone, we use it when we put a fixation for anterior external fixator. So if you have a pelvic fracture and you decided to put anterior external fixator, you will put the pin from the anterior inferior iliac spine to the posterior superior iliac spine, and this corridor of bone here called the teardrop, and this teardrop shows up in the obturator outlet view. So obturator outlet view. So obturator outlet view will give you that teardrop. It's the corridor of the bone between the anterior inferior iliac spine and the posterior superior iliac spine. And the teardrop of the hip is between the cotyloid fossa on one side laterally and the quadrilateral plate. The hip joint is a ball and socket joint. It allows 3 degrees of freedom, which is flexion, extension, abduction, adduction, and axial rotation. It does not allow the other 3 degrees of freedom, which is the translation mediolateral, translation anteroposterior, or axial translation, which is shortening and lengthening. So hip joint, ball and socket, it allows 3 degrees of freedom: flexion, extension, abduction, adduction, and axial rotation. The hip joint, the maximum pressure in the hip joint is in the position of extension, internal rotation. That's why with most hip pathologies, to decrease the pressure inside the joint, because there is effusion, the patient will be in the position of flexion, external rotation. So it's the reverse. So the maximum pressure in the hip is extension, internal rotation. If there is an effusion, which happen in most pathologies, for the patient to decrease the pressure inside the joint, it will be put in flexion, external rotation. And that's why when you examine people with chronic hip pathology, you will find in most cases they have flexion contracture and external rotation contracture. Now let's discuss ligaments of the hip joint. There is three main ligament, which is the iliofemoral from the ilium to the femur, femoral from the pubis to the femur, and the ischiofemoral from the ischium to the femur. The strongest ligament of the hip, and actually one of the strongest ligament of the body, is the iliofemoral ligament, and its other names for this is Y ligament because it looks like a Y, and another name, of course, is ligament of Bigelow. And this ligament goes from the anterior inferior spine to the anterior intertrochanteric ridge, and it's one of the strongest ligament in the body. The ischiofemoral ligament is important in limiting hip internal rotation, so it prevents the hip from internal rotating, both in flexion and extension. So the femoral triangle is an area in the upper part of the thigh where the vessels and nerves are. It is important anatomical area that commonly comes in the exam. First, we need to know the borders. The borders are the inguinal ligament proximally, medial border of the sartorius, and medial border of the adductor longus. So sartorius, adductor longus, and inguinal ligament. Now, the floor itself is the iliopsoas muscle, followed by the pectineus muscle, followed by the adductor longus muscle. So if you notice, the adductor longus is part of the border and part of the floor, because the floor is actually the medial border of the adductor longus, so the muscle, the adductor longus is part of the floor. So the floor is iliopsoas muscle, pectineus muscle, and adductor longus muscle. Borders, inguinal ligament, adductor longus, and sartorius. Then the contents from lateral to medial is, as we discussed that before when we discussed the approaches, the femoral nerve, then the femoral artery, then the femoral nerve, and the deep inguinal lymph node. So the most medial structure is the vein, the most lateral structure is the nerve. Remember, the artery and the vein are within the femoral sheath. The nerve is not within the femoral sheath.